The Diagnostic Statistical Manual of Mental Disorders, the DSM, is the most widely accepted diagnostic system now in its 5th edition. It's known as the DSM-5. Another widely used system is the International Classification of Diseases, the ICD, published by the World Health Organization. It's in its 10th edition, and with Canadian enhancements and modifications, the system is known as the ICD-10-CA, which has been adopted as the Canadian standard for coding, reporting, and tracking health information. For our purposes in this class, we're going to focus on the DSM-5. So how do we classify abnormal behavior? Well, the DSM-5 contains classifications and models of abnormal behavior. The emphasis is on classifying disorders, not classifying people. Classification is at the core of the scientific enterprise. Labels make communication about psychological disorders possible, an attempt to define and discover actual diseases, mental and/or psychological disorders. The DSM-5 uses specific diagnostic criteria to group patterns of abnormal behavior that share common clinical features. The strength of the DSM-5: it includes the use of specified diagnostic criteria of the person's disorder. The weakness of it: it includes questions about reliability and validity as being questionable, and about the medical model framework that it's founded on. Additionally, there has been a criticism regarding its use of categorical approaches to the diagnosis of disorders, which has been addressed in the DSM-5 released in 2013. The DSM-5 classifies abnormal behavior patterns or mental disorders according to developmental models. This allows relevant lifespan information to be included in decisions regarding clinical diagnosis. And that's really important in regards to seeing the whole person. Moreover, the DSM-5 deliberately employs dimensions rather than categories in evaluating abnormal behavior. Dimensions is kind of like a sliding scale. So rather than boxes of categories which might not fit everybody, you may have degrees of some sort of disorder. When a diagnosis of a mental disorder is made, other pertinent details are gathered from the individuals, such as psychosocial or environmental conditions, where you live, who you associate with. These influence persistence of disorders. The impact of disorders has on areas of the individual life are also documented. For example, a diagnosis of depression may have a significant influence on a student's ability to fulfill his or her own typical roles and functions as a student, let alone as a parent or as an employee. The DSM-5 has undergone structural changes such as the elimination of 5 levels of a multi-axis system of the previous editions. The major reorganization and regrouping of disorders also has occurred. New disorders have been added, including disruptive mood dysregulation disorder, a DMDD, a premenstrual dysphoric disorder, PMDD, and hoarding disorder. Asperger's syndrome has been eliminated in favor of a broader category named autism spectrum disorder. Although reliability and validity are essential and have been considered, they are what some critics point to regard as some diagnostic and treatment issues. Now, their cultural bound syndrome is patterns of psychological distress that are limited to one or only a few cultures. Now, you'll find an example in your textbook, TKS, which is common disorder seen in Japan. It's characterized by an excessive fear that one will behave in an embarrassing or an offending way in front of other people. Now, what we're going to moving toward is looking at treatments. Who provides treatment? Mental health professionals, clinical psychologists, psychiatrists, social workers, licensed mental health professionals, plus health professionals and counselors, psychotherapy, which is talk therapy. So methods of treatment. We're going to begin with the biological therapies. Biological approaches include drug therapy, electroconvulsive shock, and psychosurgery. Minor tranquilizers such as Valium may relieve short-term anxiety, but don't directly help people to solve their problems. Neuroleptics, they help relieve flagrant psychotic features, but regular use of most antipsychotic drugs can be associated with the risk of a debilitating side effects. It's known as tardive dyskinesia. Antidepressants have been shown to be effective in treating depressive disorders, and lithium has been shown to be effective in treating bipolar. Now, ECT, this is electroconvulsive therapy, is often associated with dramatic relief from severe depression, but questions remain about the side effects. And psychosurgery is conducted only rarely because of adverse consequences. Deep brain stimulation involves implanting electrodes within the part of the brain that is affected by mood. There is some positive effect for mood elevation for severe obsessive compulsive disorder and Parkinson's. However, it's limited and not approved for other disorders like depression. Now, when we look at psychodynamic therapies, originated with psychoanalysis, that's Freud's work, the approach to treatment developed by Freud, psychoanalysis used techniques such as free association and dream analysis to help people gain insight into their unconscious conflicts and work them through in the light of their adult personalities. So other therapies can last many months. Some of these therapies can last many years. So free association, this is continue to talk about whatever is on your mind. You just let your mind wander. The therapist is out of sight. That's why you see them on the couch somewhat behind the individual. And after many sessions, the therapist offers an analysis of patterns, disclosures, and drawing your attention to potential connections. Transference. Through therapy, a client may not only interact with the therapist as a therapist, but also as another important person in their life. This can be helpful, as in role-playing, or problematic in clients' relationships when they expect the same level of caring or feedback from those people. More recent psychoanalytic therapies are generally briefer and less intensive. These newer psychodynamic therapies still look to the unconscious, but are more focused on the present, and they sit face to face rather than behind, and play a more active and engaging role in the client's life, in terms of therapy at least. Behavior therapy applies principles of learning to help people make adaptive behavioral changes. Behavior therapy techniques include systematic desensitization, gradual exposure, modeling, aversive conditioning, operant conditioning approaches, social skills training, and social control techniques. Humanistic approaches focus on the client's subjective, conscious experiences in the here and now. Rogers' person-centered therapy helps people increase their awareness and acceptance of inner feelings that have met with some social condemnation or have been disallowed or disowned. So it's really about changing the inner surface of awareness with outside experiences. And the effective person-centered therapist possesses the qualities of unconditional positive regard, empathetic understanding, and genuineness and congruence. So it's not a questioning type of therapy, it's an acceptance of a person therapy. Now, in line with this, under the humanistic approach, is the emotion-focused therapy, and it focuses on helping to recognize one's maladaptive emotions and discover more adaptive responses or emotions. Cognitive therapies, well, they focus on modifying the maladaptive cognitions. Remember, cognitions is thinking patterns or thinking. So the maladaptive cognitions that are believed to be the underlying emotional problems in self-defeating behavior. Ellis's rational emotive therapy focuses on distributing the irrational beliefs that on occasion create emotional distress and substituting adaptive behavior for maladaptive behavior. Now, Beck's cognitive therapy, it focuses on helping clients identify, challenge, and replace distorted cognitions such as the tendency to magnify the negative events and minimize personal accomplishments. Donald Mickelbaum, he created what is known as the cognitive behavior therapy, and it attempts to integrate behavioral principles and cognitive techniques in a way that reduces or eliminates problematic behaviors and changes dysfunctional thoughts and cognitions. Eclectic therapists make use of multiple models of psychotherapy. In technical eclecticism, therapists use techniques from different approaches without necessarily adopting the theoretical models in which they were based. In an integrative eclecticism, the therapist attempts to synthesize and integrate diverse theoretical models. Now, alternatives can include group therapy, which has several advantages over individual treatment, such as it reduces cost, opportunities for shared learning experiences, and mutual support, increased utilization of scarce therapist resources. Now, the particular approach to group therapy depends on the orientation of the therapist. Now, this can include family therapy. Now, family therapists work with conflicted families to help them resolve their differences. Family therapists focus on clarifying family communications and resolving role conflicts, guarding against scapegoating individual members and helping members develop greater autonomy. Marital therapists focus on helping couples improve their communication and resolving their differences. In addition, you can find computer-based interventions. And here, the interventions and therapies come in all forms, from online cognitive behavior therapy with a live therapist using video chat, to self-guided behavior therapy for children with anxiety. Computer-based interventions for various disorders have the potential to dramatically expand and alter the landscape of treatment. Does psychology work? Well, psychotherapy researchers have generated encouraging evidence of the effectiveness of psychotherapy. Although there are a few well-designed head-to-head comparisons, comparative treatment studies, the results of meta-analysis of research studies that compare psychotherapy with a control group supports the efficacy of various approaches to psychotherapy. The results of some 375 controlled studies comparing varying types of therapies, psychodynamic, behavioral, humanistic, etc., against control groups showed that the average psychotherapy client in these studies was better off than 75% of the clients who remained untreated. In your textbook, you can read about Edmund Yu. That's on page 83 and 84. The legal process by which people are placed in psychiatric institutions against their will is called psychiatric or civil commitment. Now, psychiatric commitment is intended to provide treatment to people who are deemed to suffer from a mental disorder and to pose a threat to themselves or others. Now, legal or criminal commitment, by comparison, involves the placement of a person in psychiatric institution for treatment who's been acquitted of a crime by reason of insanity. Clear evidence, imminent risk, and a limited time is what's involved in legal and criminal commitment. In voluntary hospitalization, people voluntarily seek treatment in a psychiatric facility and can leave on their own accord unless the court rules otherwise. So when we think in terms of who's the most dangerous, if you will, look at the three examples here. Is it the apparently drunk driver, A? Is it the institutionalized psychiatric patient? B? Or is it the scheming corporate executive Bernie Madoff? You can check on page 33 for a little clarification, but it's interesting who we would see as being the most dangerous. Although information disclosed by a client to a therapist generally carries the right to confidentiality, the California Tarasoff ruling held that therapists have a duty or obligation to warn third parties of threats made against them by their clients. Now, this particular ruling does not apply in Canada as of yet. The right of treatment? Well, the right of treatment includes the least restrictive technique. So this would be techniques like techniques in terms of restriction, community over institutional care, wherever it's available, whenever it's possible. The right to refuse treatment, well, if you read Edmund Yu on page, about Edmund Yu on page 83, 84, he would have the benefit from treatment, but he's not at imminent risk, so he could and did refuse. Now, most people who need care don't refuse. Now, this completes the overview and the introduction to abnormal psychology, and we'll begin in week 3 to explore different types of psychological disorders, the theoretical perspectives to explain them, and the treatments and options available that are current. Now we'll start next week with Chapter 3, Anxiety, Obsessive Compulsive, and Trauma and Stress-Related Disorders. Okay, now everybody, good luck and carry on the good work.